Podemos hacer sono vivo, ¿verdad? Hello. Hello, good afternoon. I would like to show you today a very interesting case that we receive in our unit. This is a 50-year-old man with a history of pancreatic mass, recently diagnosed, and weight loss. In addition, this patient have an important pain, pancreatic pain, epigastric pain with irradiation to the back, and is under a lot of medication, including opioids. Okay, so now this patient, I don't know if you are looking now the U.S. So you see, I am in the head of the pancreas, and I see this hypoechogenic mass, very irregular mass, with invasion of the splenic, portosplenic trunk here. So you can see here. So the mass is here. There is an invasion of this area. So this mass have 31 millimeters by 34 millimeters. So this is a patient with probably pancreatic cancer. So you can see here, this is the mass. So a Doppler, there is also no flow in this area. So, to my opinion, this patient have already an invasion of the portosplenic area. In addition, there is a lot of interesting data. This patient have some lymph nodes here. Okay, round lymph nodes, and there is a lot of sludge inside the bile duct. You see here. Okay. So he's a little bit. There is a small amount of jaundice in this patient, and the gallbladder here, as you can see here, okay, is with a lot of sludge also. So there is an obstruction in this patient. There is a not heavy obstruction, but there is a very good dilation dilatation of the a small dilatation of the bile ducts. And I am coming here now. I am in at the level of the stomach. So this patient have a pancreatic pain due to this mass. This probably is pancreatic cancer, and there is also an irregular main pancreatic duct here. So you can see here, and it's completely dilated also. So there is a big suspicion of this patient have a pancreatic cancer. So I will use complementary technology in this case, just to see first to take some decisions that I need to take to do, because these the differential diagnosis, one is the possibility to have chronic pancreatitis with a mass, pseudotumoral chronic pancreatitis, and I will use now elastography that can be used in these scopes, Pentax scope, just to see if this tissue is hard or not hard. So we can see that this completely blue, and it's very suspicious to be a very hard tissue. And I will perform a strain radio comparing the mucosa with the mass, and the quantification analysis here, as you can see here in your monitor, is 64 when you are comparing both area, the hard versus no hard area. So this let me know that this is a very hard tissue and probably a pancreatic mass. And also we can use contrast. Why to use contrast? Because it's because if this mass have hypo enhanced, this probably is pancreatic adenocarcinoma. So you can see here the mass again, and I will use contrast now just to see if this lesion is a pancreatic adenocarcinoma, just to be sure. I will use my needle also, but with this I will take some kind of different decisions. First one, if this patient we can use neurolysis, and second one, at this level with all of these things that we saw in this lesion, so we will perform an ERCP pouring directly metallic stent, and in this case I will use a fully covered stent just to improve the jaundice of this patient. Me avisa cuando estés listo. Okay, so I will start, puedes empezar. I will start my contrast evaluation. So we are using Sonoview is hexafluoride of bubbles of hexafluoride, and we will start to see here the bubbles. You see here the vessel, so this is a hyper captation, but you can see here my mass. This mass doesn't have any captation of contrast. In this moment I can confirm that probably this mass is not inflammatory lesion. This is probably with this elastography that is very hard tissue and no captation of contrast. I can be sure that this is probably with 95% of accuracy that this is not a benign mass. So now I will change my scope. I will use now I will use a linear scope. No, quiero una 22. And I will use a fine needle biopsy using an acquired needle. I will use a 22 gauge needle because I cannot use the same needle to perform my aspiration of the mass and then to perform my neurolysis. So I will use also for my neurolysis a 19 gauge needle, a standard needle, with bupivacaine, 10 ml, and 10 ml of absolute alcohol, 99%, 98%. But before I will start using performing my fine needle biopsy, okay? I didn't see any lymph nodes in the thorax area or in other part of the abdominal area, just peripancreatic lymph nodes, but I don't need to perform my biopsy there. So now I will so I will use first my here again my mass. I am in a very good position. I will use my 22 needle. Me das la aguja, por favor. I will take some tissue here for histopathological evaluation. So, what is the difference from these needles from the other ones is that this needle have the tip of the needle is totally different. Really have improved a lot of the quality of tissue. There's a lot. There's some publication from Napoleon Bertrand, my mentor, and from other teams from Europe and United States regarding okay. Okay, puedes retirarla esta. So I am inside the mass. Retira. Aspiración. It's a very hard mass. I prefer to use my aspiration. I have better results and good results using my aspiration. And all the material I will send in formalin directly. You can see the needle very well. I don't have blood in my aspiration, so I know that I am very good position. I am having a very good sample tissue of this lesion. Okay, so we'll see what we have now. It looks like there's a good sample tissue inside the needle. So I will show you in few seconds on this. So I would like to explain a little bit why I use all of this technology. So uh, there is something very important, that is I will change the way as I will treat my patient. Okay, the studies performed around the world regarding elastography and contrast enhancement. Um, when you use both technique, you can increase the accuracy of your diagnosis or your suspect of diagnosis here. So we have a patient with a history of probably a cancer, pancreatic cancer, and with the with the complementary technology that is elastography and contrast, we have we increase the diagnosis or the suspect of diagnosis here. No sé si podemos poner la cámara, por favor. So here I have a very good material. The quantity of material is very nice. You can see here there is a lot of material. So one pass is enough. And now I will go out and I will looking for my celiac trunk now. I will perform my neurolysis before the ERCP. So this is the aorta. You can see here the aorta. So I will follow my aorta just to looking for my celiac trunk. So the celiac trunk, I think, is here. So we need to follow the vessels. I think there is something here. There is the splenic here. The splenic branch here. You see here? That's why this patient have pain. There's an invasion here, and I cannot see very well You see here, this is my celiac trunk here, and the mesenteric vessel here, down. So I need to find a very good position before to start my, okay, here. Here, there is a celiac trunk here. Perfect. Before to start my neurolysis. I will confirm here, you see. So this is the aorta, and here start my celiac trunk. Okay, fantastic. So now I will use a 19-gauge needle. I use the standard needle. There is a very good needle from Cook. I don't have in my unit now, but you can pass here. This is the stomach wall. You need to be very sure to be in this space and not to be inside the wall, the stomach wall, or the GI wall, because you can perform a necrosis of this. Okay, so it's very important to be here in this point at this level, as you can see here. And also I recommend to perform an aspiration before to start to deploy the liquid. Moreover, before to deploy the alcohol, because could be lethal if you put inside the vessel. Okay, so I need the needle. Préstame la aguja. Sí, 19. Estándar, ¿ah? Es una spec. I will use an spec needle, standard spec needle. And I will put first the bupivacaine inside, and then in the second step I will put the alcohol. Okay, I am trying to explain step by step. There is some question from people who perform US. Sometimes what happen if we pass inside the vessel? So first, if you pass with the needle, there is not a big problem. It's not a big deal. The problem is if you inject inside the needle. So you need to be sure that you know you are not inside. Okay, just to avoid complications. This is my point. This is here. You see a hypoechogenic area. I think there is a lymph node inside there. Okay, I just passed. I need to see the tip of my needle. I am trying to do that. Just a small, you see here? The tip is here. It's perfect. You see? Here is the needle. So I am sure that I am not inside the wall. I am sure that my tip is inside the area of the celiac trunk, and I will ask to my nurse to give me the aspiration. I will perform my aspiration, just to be sure that I am not inside a vessel. So I don't know if we can see with the camera. There is not blood. ¿Podemos ver la cámara? There's not blood coming here. So I'm sure that I am in a very good position. Now, I am already fixed with my needle. I am very good, in a very good position here. This is the tip of my needle, okay? And I will use first bupivacaine. Dame bupivacaína, 10 ml. This was the first US therapeutic. Now I will inject. You see? Perfect. I in the cavity. You see here? You see? Is everywhere. And now I will pass the alcohol. You see? When I am passing the alcohol, I will see very white because I am really burn this area. Finish. You need to see the pressure. The blood pressure is perfect. And we finish. Okay. So that's all. I will continue without cameras. I will perform the ERCP just to put a metallic stent, fully covered in this case. And we finish the transmission. Thank you.